Welcome everyone. In this session we will be studying about the acoustic neuroma and the facial nerve. First, acoustic neuroma. It is also known as vestibular schwannoma or neurilemoma. It is a benign tumor rising from the Schwann cells of the vestibular nerve in the cerebellopontine angle, which is a triangular area. Now it is the most common site of neurilemoma is the fourth nerve. Acoustic neuroma, it is the most common CP angle tumor, that is cerebellopontine angle tumor. Now point to be noted here is that though we are studying about the 8th nerve neurilemoma, it is not the most common tumor in this nerve. The most common tumor neurilemoma, it is of the 4th nerve. Now it is a slow growing tumor with very rare malignant potential. Histologically it can be divided into two types. First is Antony type A and the other one is Antony type B. The difference being, in Antony type A, the cells are uniform, compact and spindle shaped, while in Antony type B, the cells are less uniform and cells less cellular. So this classification is based on the histology of the two types. Now clinical features, they depend on the size of the tumor. Divided into 5 stages, stage 1 is the autologic stage in which the tumor is up to 2 centimeters in size. There is unilateral progressive sensorineural hearing loss. Also, the facial nerve involvement and the sensory part of the facial nerve is involved earlier. Second stage, the 5th nerve involvement. When the tumor size is more than 2 centimeter, it is known as extrameatal. Then comes stage 3. In stage 3, the brainstem and cerebellar compression occurs. In stage 4, there is increased intracranial pressure, while stage 5 is the terminal stage in which there is herniation of the cerebellar tonsils, failure of vital centers in brainstem. So 5th nerve is the earliest nerve to get involved. So the earliest sign is the loss of corneal reflex. It is asked as a multiple choice question. Which nerve is earliest involved in acoustic neuroma? So 5th nerve is earliest involved and loss of corneal reflex is the earliest sign elicited. 7th nerve is also involved. So because of the involvement of 7th nerve, there is one sign which is known as Hesselberger's signs, in which there is hypoesthesia of the posterior meatal wall. In earlier sessions also we saw in the nerve supply of the pinna. There is also loss of taste and lacrimation because of the 7th nerve involvement, and in later stages 9th and 10th cranial nerves are also involved, which can lead to palatal, pharyngeal and laryngeal paralysis. And lastly, cerebellar signs are also there and signs of increased intracranial tension. So how to diagnose a case of acoustic neuroma? Initially, we have to do some audiological investigations, for example, pure tone audiogram, in which there will be sensorineural type of deafness, which is more marked in higher frequencies. In speech audiometry, the speech discrimination score, it is very poor. Now all these signs, they are of the retrocochlear lesion, which we saw in the previous sessions, and the difference between the cochlear and the retrocochlear lesions. Again, rollover phenomena, that is reduction in the sound discrimination score when loudness is increased beyond a particular limit. That is known as rollover phenomena. It is a characteristic of a retrocochlear lesion such as acoustic neuroma. Lastly, stapedial reflex decay is present. And in caloric test, it shows an absent or a diminished response. Investigations. So MRI with gadolinium contrast, it is the gold standard for diagnosis of acoustic neuroma. Many options may be given to you, for example, plain MRI, CT scan or MRI with contrast. So MRI with gadolinium contrast, it is the gold standard for the diagnosis of acoustic neuroma. CT scan, vertebral angiography, they are also useful. Now BERA. What is the importance of BERA in acoustic neuroma? Now since acoustic neuroma, it is a retrocochlear lesion, in BERA there is increased interaural 5th wave latency. And differential diagnosis. Acoustic neuroma should be differentiated from some other diseases or tumors which are present in the same area. For example, meningioma. Now it is the second most common cerebellopontine angle tumor after acoustic neuroma. Other one is epidermoid, also known as cholesteatoma, arachnoid cyst or schwannoma of some other cranial nerves. 5th being more common, followed by 7th, 9th, 10th and 11th cranial nerves, or aneurysm and glomus tumor. So these come in the differential diagnosis of acoustic neuroma. Now management. Surgery is the mainstay of the treatment. surgery depends on the size of the tumor. Various approaches are there. Now, the middle cranial fossa approach, it is done for small tumors. Translabyrinthine approach, it is done for tumors which are more than 2 cm in size. Suboccipital or retrosigmoid approach, it is another approach. And one more modality of treatment is the radiotherapy. In that, stereotactic gamma knife, that is cobalt 60 radiotherapy, has proved to be very useful in reducing the size of the tumor. The second topic of this session is facial nerve. It is a mixed nerve. The motor nucleus is situated in the pons and it supplies the muscles of the facial expression and muscles of the second pharyngeal arch. It has a sensory part which is known as nerve of Risberg. It is secretomotor to lacrimal, submandibular and sublingual glands. Also, it carries spatial sensations, that is taste sensations from the anterior two-thirds of the tongue. General sensations from the concha and the retroauricular skin. So this is the sensory part of the facial nerve. The facial nerve hooks around the nucleus of the sixth nerve, that is abducens nerve, and this phenomenon is known as biotaxis. Sometimes it can be asked as a question. Now, course of the facial nerve. So course of the facial nerve can be divided into three parts: intracranial part, intratemporal part and extratemporal part. First of all, intracranial part, that is from the pons, that is from the nucleus of the facial nerve from which it arises, to the internal auditory meatus. This part is around 15 to 17 millimeter in length. Second part is intratemporal part, that is the course of the facial nerve in the temporal bone. It is a very important part as far as surgery is related. This part is from the internal auditory meatus to the stylomastoid foramen. Now it has 4 further segments. The intratemporal part has 4 further segments. First is the meatal, that is within the internal auditory meatus, around 8 to 10 millimeter the length, and it is within the internal. Just to recollect, we saw in the previous session that the facial nerve was in the anterior superior part of the cross section of the internal auditory meatus. Second intratemporal part is the labyrinthine segment. It is 4 millimeter in length. Now, MCQs can be framed from this, that it is the narrowest and the shortest segment of the facial nerve, from the fundus of the internal auditory meatus up to the genicular ganglia. It is most commonly affected by the disease. So whenever a patient comes with complicated CSM, facial nerve palsy, then this part is affected very often. The third segment is the tympanic or the horizontal segment, around 11 millimeter in length, from the genicular ganglia up to the pyramidal eminence. And the last segment of the intratemporal part is the mastoid or the vertical segment, which is around 13 millimeter in length, from the pyramid up to the stylomastoid foramen. Now the third part, that is the extratemporal part of the facial nerve. It is from the stylomastoid foramen up to the peripheral branches. The peripheral branches, they come out from the stylomastoid foramen and spread like this. So this is known as pes anserina. There are 5 peripheral branches: T, Z, B, M, C. Temporal, zygomatic, buccal, mandibular and cervical. These are the peripheral branches of the facial nerve. Now in this table, we will see the branches of the facial nerve, from where they originate and what structures they supply. So first of all, the first branch of the facial nerve is the greater superficial petrosal nerve. It arises from the geniculate ganglia and it supplies the lacrimal glands and the nasal mucosa. Second branch, it is the nerve to stapedius, which originates from the second genu and supplies the stapedius muscle. The third branch is cauda tympani. It arises from the middle of the vertical segment and it supplies the submandibular, sublingual glands and also the anterior two-thirds of the tongue. Now there are some communicating branches which supply the concha, retroauricular groove, posterior meatus and outer surface of tympanic membrane. Then there is one branch, posterior auricular nerve, which supplies the muscles of pinna and occipital belly of occipitofrontalis. Muscular branches are also there, which supply the stylohyoid and posterior belly of digastric. Now remember, these are the second arch muscles. which are supplied by the facial nerve. And peripheral branches, as I told you, TZ, BMC, pes and sinus, they supply the muscles of the facial expression. Now, injury to the facial nerve. Injury to the facial nerve can be divided like it is. First stage is the neuroplexia. That is, there is only conduction block to the flow of the exoplasm. There is no permanent injury. It is a reversible injury in which once the pressure is removed, the nerve functions normally. Second grade is axonotomesis. That is injury to the axons. And the last stage is neurotemesis, injury to the nerve. There is one classification known as Sunderland classification. He classified the nerve injuries into 5 degrees, right from neuroplexia up till the complete transaction of the facial nerve. Now, facial nerve functions test. There are various tests to test the function of the facial nerve. They are broadly divided into 2 categories. One is the electrodiagnostic test and others are the topodiagnostic test. First, we will look at the electrodiagnostic test. Now, electrodiagnostic test, in that the first test is the nerve excitability test. Now, what is nerve excitability test? It is the minimum amount of a current which is required to stimulate the facial nerve. Second is maximum stimulation test. It is the amount of current which produces a maximum stimulation of the facial nerve. Third one is electroneurography. Now, a word of caution here, it's a misnomer, because in this test muscle action potential is recorded and not that of nerve, though the name is electroneurography. Now, these electrodiagnostic tests, they are very useful between the 3rd and the 4th day of the 3rd to 14th day of the onset of palsy, and they are the best guidelines for nerve decompression and prognosis. So a question can be asked that following tests are important in the acute case, acute injury or chronic injury. So all these tests, they are more important in the acute stage of the injury. The other test is electromyography. It is not useful in acute palsy. It is used to follow the course of the denervation. That is, after the 21 days of injury, EMG or electromyography is useful. The second part of the test of the facial nerve function is topodiagnostic test. This test is to localize the site of the lesion. In this test, the first comes is Schirmer's tear test. In this test, a filter paper known as Wortmann's filter paper, it is kept in the lower fornix of the eye, and amount of wetting, it is measured in millimeters. So, if there is injury to the greater superficial petrosal nerve or proximal to that, the Schirmer's eye test will be negative. That is, the filter paper will not be wet because of the loss of lacrimation. Other test is stapedial reflex test. We all know that in a stapedial reflex arc, 7th nerve is also involved. So if there is injury to the 7th nerve proximal to the nerve to stapedius, we can diagnose it. Third test is taste test. That is, the patient's ability to taste a substance is measured, and electronically it can be measured by using an instrument known as electrogustometer. Next test is the salivary flow test. In this test, the amount of saliva being produced on a particular site is measured and it's compared with the normal site. Now, facial nerve can also be involved. Facial nerve injury can be due to the trauma. So basically there are 2 types of trauma which affect the temporal bone: the longitudinal fractures and the transverse fractures. And there are basic differences between these 2. First of all, the longitudinal fracture, they are more common than transverse fractures, and they occur from a parietal blow, that is blow from side. Suppose if somebody hits here, so there are more chances of getting a longitudinal fracture of the temporal bone. And the transverse fracture, they occur from the occipital blow, that is if somebody hits from behind in this region, so transverse fractures occurs. In longitudinal fracture, the fracture line, it is parallel to the long axis of petrous pyramid, starts at squamous part of the temporal bone to the foramen lacerum. While in transverse, the fracture line, it runs across the petrous pyramid, starts at foramen magnum or the jugular foramen. Now, ear bleeding, injury to the ossicles and tympanic membrane, it is more common in longitudinal fractures. So we can see that external ear, it is more common being involved in the longitudinal fractures as compared to the transverse fractures. And hearing loss in longitudinal fracture, because of the involvement of tympanic membrane and external ear, the hearing loss is of conductive type in longitudinal fractures, while it is of sensory neural type in transverse fractures. And facial palsy and vertigo, they are more common in transverse fractures because it is involving the deeper part of the temporal bone. Another important topic in facial palsy is the Bell's palsy. What is Bell's palsy? It is a facial palsy of acute onset, idiopathic nature, and peripheral involvement. That is, it is a lower motor neuron type of palsy. Various etiologies have been proposed. The most common being the viral, that is herpes simplex, herpes zoster, and Epstein-Barr virus have been proposed as an etiology for the facial palsy, Bell's palsy. There is one classification which is House-Brackman classification, which measures the severity of the facial palsy. Now, steroids, they are the mainstay of treatment of the Bell's palsy. Prednisolone at the dose of 1 milligram per kilogram per day in divided doses is the mainstay of the treatment. There is one phenomenon which is known as Bell's phenomena. Now, on attempting to close the eye, the eyeball turns up and out. This is diagnostic of Bell's palsy, Bell's phenomena. Facial palsy can also occur in some other syndromes. For example, Melkerson's syndrome. Now, it is a triad of facial palsy, swelling of the lips, and fissured tongue. So, this can be asked as a question like Melkerson's syndrome. Other syndrome is Ramsay-Hunt syndrome. We saw in previous sessions, also known as herpes zoster oticus, in which there are multiple vesicles formed over the pinna along with the facial palsy. There are some causes in which there is recurrent facial palsy. These are Bell's palsy, Melkerson's syndrome, diabetes, and also sarcoidosis. It has been seen that in diabetes and sarcoidosis, a patient can complain of recurrent attacks of facial palsy. Now, there are some conditions in which there is bilateral involvement of the facial nerve. Normally, Bell's palsy is of unilateral involvement, but in some diseases like in GBS, Guillain-Barré syndrome, sarcoidosis, sickle cell disease, acute leukemia, bulbar palsy, and leprosy, bilateral involvement of facial nerve is seen. Now, all these conditions are systemic diseases. So, complications of the facial nerve paralysis. First is exposure keratitis. Because the patient is unable to close his or her eyes, so because of the long exposure, keratitis occurs. Synkinesis. Synkinesis is mass movement. Crocodile tears or gustatory lacrimation. It can be asked as a question. When the patient eats, tears come out because of the faulty innervation of the muscles. Other one is Fraze syndrome. Again a question, that is gustatory sweating. When a patient eats, the sweating occurs over the parotid region area. Now, if there is acute nerve injury and some other nerve is to be used as a nerve graft, so what are the good candidates? They are the greater auricular nerve, lateral cutaneous nerve of thigh, and sural nerve. These three nerves, they are most commonly used as nerve graft in facial nerve surgeries. This is all for this session.